If you've been injecting leg spider veins by microsclerotherapy for a while, you've probably come across this problem: spider vein resistance. You've treated a patient with leg spider veins. Your injection technique was sound. The concentration of sclerosant was appropriate. The vessels blanched on injection. There was minimal bleb formation, but at the 6-week review, the spider veins are still there. Or maybe they've cleared partially and then come back in exactly the same place. Or, in some cases, they simply didn't respond at all. It doesn't happen very often. Microsclerotherapy is usually effective, and 95% of people are pleased or very pleased with the results. But when it does happen, it's a familiar and frustrating problem. And the usual response is questioning your needle placement, your concentration, your compression protocol. It's entirely understandable. But in most cases, it's not your fault. Your technique is not the problem. It's the vessel that's the problem. In this video, I'm going to explain why some leg telangiectasia resist microsclerotherapy, why that resistance is frequently a function of vessel size rather than anything you've done, and what the current published evidence supports in terms of changing the approach when standard microsclerotherapy just isn't working. And just to be clear, I perform both microsclerotherapy and radiofrequency ablation, also known as shortwave diathermy, at 4 megahertz in my practice. So what I'm going to describe is what I do when a patient's not responding to microsclerotherapy for their leg spider veins. Let's start with the clinical problem. When microsclerotherapy doesn't work, treatment resistance in microsclerotherapy takes a few recognizable forms. The first is the vessel that simply fails to clear. It's been injected carefully at appropriate concentrations in multiple sessions, and it persists. The second is the vessel that clears initially at the 3-month appointment, and when the patient comes back at 6 months, the telangiectasia are present again in the same distribution as before. The third, less common, is the vessel that seems to resist injection even from the first attempt. No sustained blanching, no progressive fading, no response after 2 or 3 courses of treatment. All 3 presentations have different underlying mechanisms and they require different responses. Here's a framework for distinguishing between them and for knowing when to change what you're doing. The instinctive response, the knee-jerk response perhaps, and why it's often wrong. When microsclerotherapy doesn't work, the natural tendency is to go back to the same approach and adjust it. Use a slightly higher concentration, change the needle, try a different injection angle, or add compression, or maybe use stronger compression for longer. Sometimes that's the right response, but often it's not, because the assumption behind it, that the problem is technical, may not be correct. If a vessel is too fine to accept the sclerosant reliably, injecting at a higher concentration doesn't resolve the problem. It may increase the risk of perivascular inflammation and pigmentation without improving clearance. It might also cause telangiectatic matting, and if a vessel recurs because it's being refilled from an untreated hemodynamic source, a refluxing feeder or perforating vessel, then changing the injection technique simply won't address that either. And that leads us to a framework based on size. This helps you ask, why is the vessel resistant? Is it the caliber or is it the architecture? Is it the pattern of vessels? Or is there a hemodynamic source driving it that needs to be identified and addressed separately? Those 3 questions lead to 3 different clinical responses, and getting to the right response depends on understanding what kind of resistance you're dealing with. And this leads us to why CEAP C1 can't explain resistance. Part of the reason treatment resistance is hard to explain in clinical practice is that we lump everything together in the classification system we call CEAP. C1 doesn't give us the language and the classification to find out why spider veins are resistant. CEAP C1 covers telangiectasia under 1 mm and reticular veins from 1 to 3 mm. In principle, that distinction is there in the system, but in practice, C1 is frequently treated as a single, undifferentiated category, and the same approach, inject, compress, review, is applied across the full range of vessel calibers. One of the unintended consequences is that the patient with fine red thread veins at 0.2 mm and a patient with reticular feeders at 2.5 mm receive broadly the same treatment. When the fine vessels don't clear, there's nothing in the C1 label itself to explain why, and without that explanation, the tendency is to repeat the same approach without a change in strategy. A classification based on size, which is consistent with the framework that Duffy introduced and supported by current published trial evidence, provides that language we need. It makes vessel diameter the central organizing principle within C1, and it aligns diameter directly with the three questions that matter most in resistant spider veins. Which modality should I use? What outcome should I expect? And do I need to investigate further before I change my approach? Let me set out the size spectrum as I think about it clinically. At the fine end, vessels at or below 0.2 to 0.3 millimeters, you're dealing with intradermal telangiectasia that have very low luminal volume and very thin walls. Their capacity to accept sclerosant without disrupting and extravasating or responding with a disproportionate inflammatory response is very limited. They're technically difficult to cannulate with a needle, and even when injection appears technically successful, the sclerosant contact time may be insufficient to produce reliable fibrosis and vessel obliteration. These are the vessels that are biologically resistant to injection. At the reticular end, from 1 to 3 millimeters, you have vessels with greater luminal volume, and they're more accessible, and they respond well to liquid sclerotherapy at appropriate concentrations. When these vessels are resistant, the cause is usually hemodynamic. Reflux from a proximal or perforating source. It's not a caliber problem. In the middle ground, roughly 0.3 to 1 millimeter, injection is technically feasible, but outcome depends on careful assessment of the individual lesion size, the pattern, and the hemodynamic context. For every resistant case, the first clinical question is, which part of this spectrum does this vessel sit in? There is good randomized evidence that vessel size changes treatment performance within C1 disease, and this matters directly for resistant cases because it tells us that the finest vessels were never well served by injection in the first place. The strongest evidence comes from a prospective randomized study by Trelles and colleagues published in 2020 involving 285 women and 570 legs. The study compared long-pulsed ND-YAG laser with 0.5% polydocanol across vessel size bands. For telangiectasia under 1 millimeter, ND-YAG laser was superior to sclerotherapy. As diameter increased within the C1 range, polydocanol became progressively more effective relative to laser. A blinded comparative trial by Weiss and Weiss from 1999 supported the same principle from a different angle, showing that treatment outcomes for small telangiectasia depend upon both the method and the vein phenotype. Goldman's narrative review from 2006 described light and laser modalities as particularly effective for vessels up to 1 millimeter. These studies converge on the same clinical conclusion within C1 disease. 1 millimeter is a meaningful dividing line. Below it, injection becomes progressively less reliable. Above it, sclerotherapy with polydocanol is the primary modality. So I want to be absolutely clear about the Trelles evidence and what it implies for resistant cases. If a patient has a cluster of very fine telangiectasia that are clearly below 1 millimeter, and particularly if they are below 0.3 millimeters, and those vessels have not responded to 2 or 3 careful courses of injection, the most likely explanation is not that the technique has been inadequate, it's that those vessels are in the size band where sclerotherapy performs less well and where laser or thermocoagulation is more likely to succeed. Continuing to inject at a higher concentration in this situation doesn't address the underlying problem. It may cause more perivascular inflammation, more hyperpigmentation, telangiectatic matting, and more patient frustration without producing better clearance. A better clinical response is to recategorize the resistance. Ask yourself, is this a caliber problem or is it a hemodynamic problem? The answer changes what you should do next. A decision framework based on the size of the vessels allows us to distinguish 2 broad categories of C1 lesion in clinical practice: responsive and resistant. A responsive lesion is one whose size, isolation, and absence of feeder reflux make it likely to clear with standard microsclerotherapy or direct thermal treatment. A responsive lesion is clearly injectable. The sclerosant makes reliable contact with the endothelium. The vessel obliterates over the following weeks. A resistant lesion is different in one or more of the following ways. It's too fine to cannulate reliably. You simply can't get a needle into it. It's densely clustered and rapidly refilling. It's recurred in the same distribution after previous treatment, or it's hemodynamically connected to a refluxing feeder vessel. These are not failures of technique. They're a different category of clinical problem. Recognizing that distinction and being able to explain it to your patient changes the conversation from "we need to try harder with the same approach" to "we need to ask why this vessel is behaving this way and choose the right tool for it." Ferrara and Ferrara published a prospective clinical trial in 2013 that operationalized this distinction formally. The study involved 63 patients and 125 limbs, and it proposed 3 types of pathophysiological subclassification systems based on vessel size and hemodynamic behavior. Now let's put this study in perspective and talk about the grade of evidence. This is a prospective comparative cohort study. It's not a high-quality randomized controlled trial, but the clinical contribution to the literature is significant, and it maps well onto what most experienced practitioners observe in their own clinics. The 3 types are as follows, and let's look at them in detail. Type A lesions are reflux associated. The telangiectasia are being driven by a hemodynamic source, typically a refluxing reticular feeder vein, a perforating vessel, or a truncal tributary. The resistance or recurrence is because the surface vessels are being continuously refilled. In these cases, changing the modality alone is unlikely to resolve the problem. Investigation with duplex ultrasound scan is the appropriate next step, and the hemodynamic source needs to be addressed before or alongside surface treatment. Type B lesions are clusters of spider veins greater than 0.2 millimeters that are not related to underlying reflux. These are accessible to injection, and standard microsclerotherapy treatment is appropriate, though they may require more than 1 session, and they need careful management of the inflammatory response. Type C lesions are isolated telangiectatic veins of 0.2 millimeters or below. These form a clinically distinct subgroup. They're technically very difficult to inject, not because of operator technique, but because of their caliber and wall structure, which make them very poorly suited to intraluminal injection. They require a different approach, and that approach, as I will describe, is thermocoagulation. The Ferrara study reported better 12-month results with a multi-therapy protocol aligned to this subclassification than with standard sclerotherapy alone. This is a prospective cohort study. It's not a randomized controlled study, but the framework it provides is clinically coherent and it's practically useful and pragmatic. You could apply it in your clinic straight away. So how do you apply heat energy? Well, you could use laser, or you can use thermocoagulation. Radiofrequency thermocoagulation, also known as shortwave diathermy, at 4 megahertz, is the modality most suited to the clinical problem. The mechanism is important to understand because it explains why thermocoagulation bypasses the limitations that make very fine vessels resistant to sclerotherapy. Radiofrequency thermocoagulation, also known as shortwave diathermy, uses a fine insulated needle to deliver high-frequency electrical energy directly adjacent to a small vessel. This produces thermal destruction of the endothelium. And here's the important part. The needle doesn't need to enter the vessel lumen. There's no injection, there's no sclerosant, and there's no requirement for intraluminal access. The limitations that matter most at this size, which are difficult cannulation, inadequate luminal volume, and insufficient sclerosant contact time, simply don't apply to thermocoagulation. In my practice, I use thermocoagulation selectively alongside microsclerotherapy, not a replacement for it. The two modalities address different parts of the size spectrum. In a typical session, I begin with thermocoagulation for the finest visible vessels, and then proceed with injection for the larger telangiectasias and reticular feeder veins. You can do it the other way around. You can treat the larger vessels and the feeder veins with sclerosant, and then you can treat the finer vessels either at the same session or at a subsequent session. Used together, where appropriate, these two modalities give a more complete response than either technique alone. The best trial evidence for adjuvant thermocoagulation comes from a randomized control pilot study by Dicken and colleagues, published in Phlebology in 2021, involving 111 patients with CEAP C1 spider veins. The study compared liquid sclerotherapy alone with sclerotherapy plus low-energy RF radiofrequency thermocoagulation. The adjuvant thermocoagulation group had better self-assessed cosmetic outcomes. They also had significantly less hyperpigmentation and less trapped blood without any increased risk of necrosis. Let me be clear. This is a pilot study. It's not a large randomized control study. But it is randomized evidence for a real clinical benefit, and it supports the selective use of thermocoagulation in precisely the size band where injection is least reliable and most difficult to perform. That finding matches my own experience in practice. The benefit is most apparent for vessels that are just too fine to cannulate reliably or that have responded incompletely to injection in a previous session. For cases where repeated microsclerotherapy has produced incomplete clearance of very fine vessels, a trial of thermocoagulation is a clinically reasonable next step before concluding that the vessels cannot be treated. And this brings us to a practical question. When you're reviewing a patient who has had an incomplete response, how do you assess at the examination couch whether the persistent vessels are in the injectable size range? Well, it turns out the most reliable and useful tool is the one you already have in your hand, your 30-gauge needle. A 30-gauge needle has an outer diameter of approximately 0.3 millimeters. No study has formally validated this as a measurement standard for telangiectasia, and I want to be clear, it's only a practical visual comparator, not a calibrated instrument. But the clinical inference is useful. If a persistent area of telangiectasia appears clearly narrower than the outer wall of your 30-gauge needle, it's likely at or below 0.3 millimeters, in the size band where thermocoagulation or laser is likely to be more successful than further injection. If it's equal to or wider than your 30-gauge needle, microsclerotherapy remains technically feasible, and the cause of resistance is more likely to be hemodynamic rather than caliber related. This is a good way to judge the caliber of vessels whenever spider veins are resistant. It also gives you something concrete to say to the patient. You can say that the vessels are narrower than the needle I would use to inject them, which is why I'm going to use a different technique for them. This, to me, sounds like a better explanation than saying those ones are very tricky. The third question to ask yourself when a patient has spider veins that are resistant to microsclerotherapy is whether there is a hemodynamic source driving the persistence or causing the recurrence. A framework based on size maps directly to the selective duplex ultrasound policy, which I discussed in a previous video and previous blog article, and I'll put the links to those in the box below. The selective duplex ultrasounds policy is supported by the UIP in 2024 and by the SVS, AVF, and AVLS in 2023, both of which recommend against routine scanning in asymptomatic C1 patients. But they clearly support scanning when clinical features suggest hemodynamic involvement. Here's the important distinction for patients who have resistant spider veins. If the resistant vessels are isolated, very fine, with no symptoms and no pattern suggesting reflux, that's a type C presentation, then duplex scanning is unlikely to change management. The next step is thermocoagulation, not imaging. If the pattern's different, if the vessels are clustered, rapidly refilling, or they have recurred after apparently adequate treatment, then resistance is more likely to be hemodynamic. Duplex scanning should be performed to identify whether there is a reticular feeder, a perforating vessel, or a refluxing truncal tributary driving the surface disease. In these cases, changing the modality alone will not resolve the problem. So let me give you a different perspective on early recurrence of telangiectasia after microsclerotherapy. When telangiectasia return in the same distribution after careful, technically sound treatment, that is not evidence that the treatment failed. It's actually, in my opinion, a clinical sign that there is a persistent hemodynamic source refilling those surface vessels. Recurrence in the same distribution is one of the strongest indications for duplex scanning in everyday clinical practice. Duplex will often identify a refluxing reticular vessel or perforating vessel that was not visible on clinical examination and which was not the focus of previous treatment. Addressing that source, either by injecting the feeder directly under ultrasound guidance or by more formal hemodynamic assessment, changes the outlook for those surface vessels. And conversely, if the same vessels return after treatment and duplex shows no hemodynamic source, the question becomes whether those vessels are type C lesions, where the limitation is caliber rather than reflux. In those cases, the right response is not repeated injection. It might be thermocoagulation. So let me bring this all together now and sum up the key points I want you to take away back to your clinic. Firstly, resistance to microsclerotherapy treatment for leg telangiectasia is actually a problem of vessel caliber and the pattern and distribution of the spider veins, which are the determining factors whether microsclerotherapy is successful or not. So before repeating the same approach, ask why the vessel is resistant. Secondly, CEAP C1 classification doesn't explain resistance. A size-based framework using vessel diameter as the primary discriminator gives you the framework to categorize resistant lesions and choose the right response. Thirdly, the 1 mm threshold matters. Randomized evidence from Trelles et al. In 2020 shows that vessels below 1 mm respond differently from larger C1 lesions. And by the way, a 19-gauge needle has a diameter equal to 1 mm. For the finest vessels, sclerotherapy may not be the right choice in the first place, not just a suboptimal one. Fourth, the Ferrara subclassification gives you 3 clinically distinct categories. Type A resistance is hemodynamic, which should be investigated and which should be addressed. Type B requires careful standard treatment, possibly across multiple sessions. Type C is biological. These ultrafine vessels need thermocoagulation or laser, not more injection. Fifthly, thermocoagulation at 4 MHz is supported by randomized pilot evidence and is a clinically reasonable next step when very fine vessels have not responded to injection. It addresses the size band problem directly without the limitations that sclerotherapy faces at that caliber. Sixth, recurrence in the same distribution is a clinical signal. It means you should scan for a hemodynamic source before concluding that treatment is not working. And finally, when microsclerotherapy is not working, the first question should be, is this a size problem, a hemodynamic problem, or both? The answer determines what you do next. The full companion article, including the Ferrara subclassification in detail, the evidence tables, and the duplex screening framework, is in the link in the description below. If you found this video useful, please consider giving it a like and sharing it. It really does help my channel. And why not subscribe? That way you won't miss my next video. My name's Dr. Haroun Gajraj. Thank you for watching.